Ryan Reynolds here from Mint Mobile. With the price of just about everything going up during inflation, we thought we'd bring our prices down. So to help us, we brought in a reverse auctioneer, which is apparently a thing.
Mint Mobile Unlimited Premium Wireless. How to get 30, 30, how to get 30, how to get 20, 20, 20, how to get 20, 20, how to get 15, 15, 15, 15, just $15 a month? Sold!
Give it a try at mintmobile.com/switch.
$45 up front for 3 months plus taxes and fees. Promo rate for new customers for limited time. Unlimited more than 40 gigabytes per month. Slows full terms at mintmobile.com.
How do you feel great on vacation? Like really good? Easy. You go to Aruba. You'll spend your time relaxing on cool white sand beaches and floating in healing blue water. You'll immerse yourself in natural wonder and find your center on an island where things move at your speed. You won't just feel great, you'll feel relaxed, renewed, and ready for life. That's the Aruba effect. Plan your trip at aruba.com.
When my son was about 2.5 years old, he told me he's allergic to black beans, olives, and clams. It's like the weirdest combination of foods. And I had no idea what was going on. And then I realized he's always been a really savvy kid. And he noticed that when adults said they were allergic to something, they didn't have to eat it. But I had seen him eat black beans, olives, and clams and not have an allergic reaction. So I said, "You know I'm a pediatrician, right?" But the truth is, there is a lot that I don't know about food allergies. They are quite complicated, and there are a lot of myths out there that just aren't true. That's why there are experts in allergy and immunology. And I have arguably the most well-spoken and entertaining of all the pediatric allergists with me today. That's next. I'm Dr. Wendy Hunter, and I'm the pediatrician next door. I'm that doctor friend you call for practical advice about your kid's health. I mix the science of medicine with the reality of parenting. If you have ever browsed social media or spoken to another human being, you have surely heard an inaccurate statement about allergies. I've seen claims that natural products are allergen-free, that a person claims to be allergic to water, and that honey treats allergies. I've got a list of myths about allergies to debunk today, and Dr. David Stukus, the director of the Food Allergy Treatment Center at Nationwide Children's Hospital in Columbus, Ohio, is going to help me. He seemed to enjoy answering my dumb questions. Here we go. Is it true that each allergic reaction is going to get subsequently worse?
Yes and no. So each allergic reaction could subsequently get better as well. So, when it comes to like food allergies, it's been sort of scared and drilled into people's minds that, oh my gosh, the first time could be just hives and the next time could be your throat will swell shut and you're going to die. And fortunately, it doesn't really work that way. But what we've learned is there are a ton of cofactors that can absolutely impact the severity of future allergic reactions. So when it comes to food allergy, for instance, how much did you eat? If the first reaction you ate one small bite and you had some hives and itching, but the next time you ate a serving size, then yes, that could absolutely cause a more severe reaction. Exercise is a huge cofactor. If you have one reaction while you're not exercising, but eat the exact same amount while you're playing soccer or playing sports, you absolutely can have more severe symptoms. Sleep deprivation can do this as well. Physical and emotional stress, if you're taking NSAIDs and Motrin and things like that, alcohol, all of these things can change the severity of reaction, as can viral illnesses and acute infection and things like that. So strictly speaking, no, it's not like future reactions will get worse. Can they get worse? Absolutely, but because there's a lot of factors involved. And oh, by the way, if you happen to have a severe reaction the first time, you may have a more mild reaction the next time. So not an easy answer.
Is there any truth to this concept of having like a pollen from something on a food and eating it and having an allergic reaction to the pollen, not to the actual food?
Sort of, but not really. So there's something called oral allergy syndrome or pollen fruit syndrome, where people with environmental seasonal allergies, so you have itchy, watery eyes, sneezing, runny nose from tree pollen or grass pollen or ragweed. There are fresh fruits and vegetables that contain similar proteins to that pollen that are often contained in the skin on those fruits and vegetables. So for some people, if they have, you have to have the seasonal allergies to even have this syndrome. But if you do, then if you eat fresh fruits and vegetables that look like the pollen you're allergic to, your body says, why are you eating a mouthful of pollen? When you're not, you're just eating the fruit and vegetable. The cool thing with this is it's very different than like a peanut allergy or milk allergy that can progress to cause more severe symptoms. You can almost always treat this by peeling the skin, heating or processing the food or cooking it in some way. Best example, people with birch tree pollen allergy in the springtime, oftentimes that cross-reacts with fresh apples. They may have itching inside their mouth when they eat an apple, but they can eat apple pie all day long. So not quite exactly what you were describing, but that's sort of a similar description.
I'm so glad I asked that question. It was just sort of off the top of my head, but that is really, really good. That's really interesting. Okay, here's my next myth. And I think this comes up a lot in schools or among people who don't have allergies. They believe that food allergies are not that serious.
No, they can be. Yeah. So we want to promote, confidence and not fear. But if you have a true food allergy, then every time you eat that food, your body's going to produce an immune response and you're going to have an allergic reaction. Symptoms can vary from hives and itching to you can progress and have swelling, you can have vomiting, you can have, wheezing and difficulty breathing, or you can pass out due to low blood pressure and go into shock. So they absolutely can cause serious reactions. Thankfully, fatalities from food allergies are not nearly as common as people are led to believe, but they do occur. So every time it does occur, it's very tragic. We try to prevent these as much as possible, but no, we need to take this seriously. Plus, if you're allergic to a food and you eat it, you're not going to feel very well. So we need to know what you're allergic to and talk about ways to avoid it. But yeah, we need to help educate everybody that this isn't a lifestyle choice.
That reminds me that I have a number of teenage patients who do have true food allergies, but for whatever reason, we all are self-destructive. Or even a lactose intolerant patient, they'll just go eat a bunch of ice cream. So I think maybe they think that eating a little bit won't hurt. Is that true or is that a myth?
Well, we've learned a lot about what's called thresholds. And this is actually like the current paradigm in food allergy management as everybody has a different threshold, which means if you line up 100 people with peanut allergy, they're all going to have, different set points as to how much they need to eat to trigger a reaction. Any reaction at all, let alone a severe, anaphylactic reaction. The only way to determine this is by actually eating it. So at our food center, we actually do something called threshold challenges. You come hang out with us for a few hours. We're going to give you very, very small amounts of peanut, like 1/30th of one peanut to start. And we're going to stop at, one whole peanut. We're not going to prove that you're not allergic to it, but we're going to try to figure out, are you exquisitely sensitive? 50% of the world's peanut allergy population needs to eat roughly 2/3 of one peanut to have any reaction at all.
Okay, that brings me to my next myth. Peanuts are the worst and most dangerous allergy. True or false?
Not for those who are allergic to milk or egg. So actually, milk and egg allergy can be quite severe, especially in young children and infants. And so we need to respect all food allergies. Tree nuts can cause severe reactions as well, particularly cashews. Of course, there's seafood and crustaceans that can cause pretty severe reactions. So no, it's a big myth. Everybody focuses on peanut. We have peanut-free schools, peanut-free playgrounds. That does nothing to help the individual with milk allergy, which can have just as severe reactions. So we really try to promote good awareness surrounding food allergies in general and not focus on one specific food compared to others.
Do children outgrow their allergies? I hear that a lot, that it's true.
Yeah, a lot of them do. So we know when we diagnose things like milk, egg, wheat, and soy allergy in infancy, the vast majority of them will naturally outgrow this by the time they're 3 or 4 or 5 years of age. So that's the expected course for them. Whereas only about 20% of individuals with peanut or tree nut allergy may actually outgrow this as they get older. It's probably less than that for things like sesame. So it's important to understand the prognosis, though, because we don't want to diagnose somebody with food allergy or allergies when they're 2 years old and say, have a nice life. It absolutely can change. The immune system is very dynamic, especially throughout childhood.
How often do you see a patient with an allergy to check in with them?
Generally, it's once a year unless they have other conditions such as asthma or allergic rhinitis or eczema. So we do want to repeat testing as time goes by. And I don't want to, oftentimes we'll do a blood test to measure the IgE levels towards that food. I don't want to stick somebody every 6 months if it's not going to change a whole lot. So we generally say 9 to 12 months unless things change. But two, as children go through different stages of development and as they get older, there's different things that we need to take account for. So maybe they're going to preschool for the first time. So I like to help families navigate how do they communicate with those preschool personnel and talk about their child's food allergy. Same with when they're going to kindergarten. When they become adolescents or pre-adolescents, that's a whole different sort of area of self-management and making sure that they're up to speed with carrying their own epinephrine and communicating and reading labels and things like that. So I think it's worthwhile to touch base at least once a year.
Here's a tough question because I know this changes based on age. but children with allergies should avoid all potentially allergenic foods. How does that change, and is that a myth?
No. In case you didn't get that, no. So we need to figure out, what are you actually allergic to? So the vast majority of people will just be allergic to one food or similar. There's cross-reactivity. So if you're allergic to cashews, more likely than not, you're also allergic to pistachios, and same things with walnuts, pecans. But very few people are actually allergic to like all tree nuts. And if you're allergic to peanut, you don't need to avoid all legumes. So, we want to promote inclusion of the foods that you're not allergic to into the diet, because avoiding foods absolutely comes at a cost and can cause harm. So, we need to know exactly what you're allergic to, and then we need to guide you to eat everything else.
If you have one child who has an allergy, how does that affect how you treat your other children?
So younger siblings are actually at less risk to develop food allergies. So we see this a lot. So there's a couple scenarios here. So one is if you're expecting new children after your older child has been diagnosed. So there's actually lower risk for young children. And the strongest risk factor is actually eczema. So if the baby has moderate to severe persistent eczema beginning in the first couple months of life, that's the strongest risk factor to develop food allergies. The genetic predisposition is to become allergic in general, but not to become allergic to the same exact thing that parents or older siblings are allergic to. But then there's the other concept of, if you have, say, a 5-year-old at home with a certain food allergy, how then do you introduce that same allergy to the younger siblings? And we spend a lot of time talking to families, providing reassurance, talking about safe practices to wash surfaces. Soap and water can adequately remove any food allergen from hands and from surfaces, and how to sort of limit feeding to the table and not walking around the house so crumbs can fall and things like that. But yeah, that's a great question. It's an important conversation to have.
There's a lot to that as well.
Mm-hmm.
A couple of follow-up questions, but I'm going to only give you one. And here's the myth that you must wait 3 days between introducing new foods to a baby.
No, it's actually 2.7999 days. No, so I actually asked like the world's leading food allergy dietitians. I said, where does this come from? What's the evidence between waiting 3 days, 5 days, 7 days, 10 days? There is none, no evidence at all. This goes back to the ultra-conservative approach to the fact that we've scared the hell out of parents everywhere in feeding their babies. At some point in the last 20 years, this became a medical procedure. It is not. So there is no reason to wait 3 days. I think the understanding was, well, if something were to happen, then you know exactly what food were to cause it. Well, let's flip that on its head. So, for example, only 1% to 2% of all children will ever develop a peanut allergy, no matter when you feed it, how you feed it, what form. So if we're telling 100% of parents to be really cautious, wait 3-5 days, that's a disservice to the 98 to 99% of parents whose child will never have a peanut allergy. So I like to think of it as, let's reinforce, let's expand their palate, expose them to different textures and different tastes, and let them play with the food and have fun with it. Then if on the off chance that they do have a suspected reaction, we can figure it out. So have fun, let the babies eat, and enjoy it.
Agree. Thank you for reinforcing that. All right, how about this? If you have a positive blood or skin test to a food, you are allergic to that food. Is that a myth or is that true?
Oh, it's a huge myth. So I actually don't even use the term positive, because that's not what these tests are designed to do. They're not pregnancy tests. It's not a yes-no answer. When we look for IgE to foods, we're looking at sort of a spectrum. So on the skin test, we're looking at the size of the bump that occurs. On the blood test, we're looking at the level of IgE towards that food. All of these are merely a guide. The most important part of the diagnosis is what happens when you eat the food. If you're allergic to a food, every single time you eat that food, no matter what form, you should have pretty rapid onset within an hour or so, reproducible symptoms such as hives, swelling, vomiting, anaphylaxis. If you are eating a food and not experiencing those symptoms, you are not allergic to that food. There's no need to do the testing in the first place. There's a lot of false positives on these tests, so they absolutely have to be interpreted in the proper context and according to clinical history. So no such thing as oh my gosh, I'm positive to this.
Do you ever have a patient who has a high IgE to a specific food, but they say, I'm eating that food just fine?
All the time. Yeah. In fact, when we do our oral food challenges, which is the gold standard to figure out if somebody's actually allergic to the food, come into my office and hang out and eat this. If you eat a whole serving, nothing happens. You're not allergic to it. Very rarely are we doing this on somebody with completely negative test results. So if somebody was previously diagnosed and their levels are trending down over time, we don't wait until they're negative. We're going to miss years of opportunity when they can tolerate it. Likewise, there's a lot of reasons why people have false positives. So, for instance, if you're allergic to things like cockroaches, that cross-reacts with shellfish. So you may have a false positive to shrimp. Same thing with dust mites. Dust mites will cross-react with shellfish as well. So if you're allergic to tree pollen, you may have false positives on testing for peanut or for tree nuts and things like that. So yeah, there's no like positive or negative that, is absolute.
There is so much to this that I personally, as a primary care pediatrician, I don't do serum allergy tests at all. Do you have advice for pediatricians about that? Because I know a lot of my colleagues do.
Yeah, so there is no indication to ever order a panel of food allergy tests. And this is problematic because these get marketed to folks like yourself on a regular basis. Wouldn't it be great if you could get one drop of blood and tell your patients exactly what they're allergic to? Well, this goes against everything that we know about testing. These are not screening tests, period. Hard stop. You can't just randomly test for a bunch of foods and then diagnose allergy that way.
All allergy-inducing ingredients have to be on food labels.
Oh, no. It depends on where you live, but let's assume your audience is mostly in the United States. There's 9 foods that have to be on every label. So if you're allergic to cow's milk, egg, wheat, soy, tree nuts, peanuts, finned fish, shellfish, or sesame, and that is present as an ingredient in that product, then it absolutely must be on there by law, and it must state contains that allergen. There are people that are, it's more rare to be allergic to things like spices and flavorings and stuff like that, but those don't have to be listed by law. So you have to learn how to read labels or sometimes call manufacturers. Or for those people who are allergic to something outside the top 9, say mustard or something like sunflower seed, that doesn't have to necessarily state contains. Ideally, it's going to have it listed in the ingredient, but there's different names that companies can use on there as well. So no, everybody needs to be aware of exactly what needs to be put on there, but we do generally teach people how to read labels and communicate and ask questions.
I shouldn't be impressed that you can rattle off those 9 ingredients or those 9 allergens, but I am. All right, here are my 2 kind of non-food allergy myths that I cannot stop thinking about these because I hear them all the time. Mm-hmm. Honey treats pollen allergies.
Here's the deal. Honeybees collect pollen from plants, and the pollen that they collect is not large enough to actually cause allergic rhinitis. So when you have allergic rhinitis, it's from really small pollen from trees and grasses and weeds and ragweed. So the pollen that honeybees collect is very different than the pollen that actually causes symptoms of allergic rhinitis. The theory is, bees make honey, so all the pollen they collect is present in the honey, and therefore if you eat your pollen in small amounts, it will sort of desensitize you. Well, 1, it doesn't contain the actual pollen that is causing your allergies in the first place. 2, if you ate a mouthful of the pollen that was causing your symptoms, you're not going to be treated. You're going to have an allergic reaction inside your mouth. Number 3, it would be extremely inconsistent between every batch of honey in regards to what pollen is in there. And then 4, the principles of desensitization are very different than eating some honey every once in a while. So we've used like allergy shots for 120 years. We have sublingual immunotherapy, but this requires persistent, ongoing, consistent exposure to your allergen through gradual increases over time for years and years and years to actually alleviate your symptoms. So there's 4 very basic reasons why this doesn't work. Don't fall for the marketing, follow the science. Can honey help soothe the sore throat? Actually, it can. So if you actually have like postnasal drip causing your sore throat, or you kind of a raw, it's just like a throat lozenge. So yeah, so eat it because it's yummy and tastes good, but don't eat it because you think you're treating your pollen allergies. And never give honey to any infant less than 12 months of age due to the risk for botulism.
Next myth. Hypoallergenic pets won't cause allergy symptoms, and they're definitely worth the money.
Yeah, no, this is a myth. This one I did discuss on television about 10 years ago, and I got basically accused of calling then President Barack Obama a liar because they had the hypoallergenic Portuguese water dogs or whatever.
Oh,
so
yes.
there is no such thing as a hypoallergenic cat or dog. The dander that causes allergy symptoms is present in the saliva, in the skin, and the urine of these animals. There's different types of dander, and we have some that cause symptoms in the majority of people with allergies to these pets. But, they often get sold for astronomical prices, stating that they're hypoallergenic. It has nothing to do with their hair length or their breed or their shedding. I promise you, if you are allergic to dogs and you're fine around a certain breed, there are other people out there that are allergic to dogs that have significant issues around that breed. Now, with dog allergy, it's interesting because many people do find breeds that don't cause symptoms for them. But again, it has nothing to do with like their hair length or shedding or anything like that. Cat lovers aren't as lucky. There tends to be pretty consistent allergenicity among the different cats. But yeah, so unfortunately, that's one where people are wasting a lot of extra money thinking that they're getting a hypoallergenic dog. So if you have a dog allergy, absolutely, can you find certain breeds that you may be fine with and you can bring into your home? Yeah, but the only way to do it is to spend time with them. And I always recommend find the dog you want, hug it, love it, let it lick your face. If you break out in hives, maybe not the right dog for you. If you don't have any symptoms, then get exposed a couple of times and maybe you can figure that one out.
Do you have any other myths that you hear often or that you really want to widely debunk?
Oh, so those are some really good ones. There's the other one about penicillin allergy of, 10% of the population has been told that they're allergic to penicillin, but 95% of those same individuals are not actually allergic to penicillin. And this goes back to what we talked about before of all the symptoms that can occur due to allergy can also occur for non-allergic reasons. So all those children out there that develop a rash on day 6, 7, 8, 9, 10 of their treatment of amoxicillin for strep throat or ear infection or something, those are very rarely true allergic reactions and they can receive it again without any problem. So if you've been told you have a penicillin allergy, please talk to your pediatrician or go see an allergist and we can clarify it because again, 95% of those people aren't actually allergic and can receive it again.
What does a true amoxicillin or penicillin allergy look like when you see it?
There's two forms. So there's the immediate onset, IgE mediated, and that's going to be I took a dose of this or typically through an IV, and within minutes I had, diffuse hives, anaphylaxis. That's very clear cut. That's pretty darn rare in kids, thankfully. And then there's the more severe types of delayed onset things like serum sickness or Stevens-Johnson or really serious like conditions where the skin is sloughing and you get organ involvement with, liver damage and things like that. Those people are generally pretty darn sick when that happens, but that's very different than somebody who just kind of gets a pink rash on their body that goes away after a couple of days.
I used to be an ER doctor and I will never forget the time I gave a kid ceftriaxone and like 15 minutes later he was like full anaphylaxis. I was like, oh, sorry.
Yeah, but I mean, so that's what we're looking for, right? So those are the allergic reactions, all the stuff in between. And also, so it's not inherited. So there's a lot of parents out there that say, don't give my child penicillin because I have penicillin allergy. So that parent probably doesn't have penicillin allergy themselves. And even if they do, they don't pass it on to their child. So no reason to avoid in that scenario either.
What else do you hear all the time that you debunk?
We were ready to rename our center within a couple of weeks of opening the Non-Allergic Irritant Contact Dermatitis Center of America because so you take all these children with like fair skin, fair skin, blonde hair, blue eyes, that sort of thing, and then food touches their face and causes redness. This is extremely common, and there's like 200 foods that can do this. We're talking things like tomato-based products, even sauces, citrus, ranch dressing, berries, cinnamon, bananas, even things like scrambled egg can do it sometimes. So it's a very big difference than I eat this and it causes hives, everywhere. So we love seeing those families to provide clarification that no, your child's not allergic to these things. This is why people think that strawberry is a common cause of allergy. It is not. I've not met anybody in 20 years of doing this that's actually allergic to strawberries. I meet people every week that do get rashes when they eat strawberries, particularly when it contacts the skin. So again, non-allergic contact dermatitis, very different than a true food allergy.
I've heard that strawberries have histamine in them and that contacts the skin. Is that right?
That can be part of it as well, yeah. So there's two flavors here. So we have children who get these rashes from 50 foods, and then we have those that just get it from like strawberries, and then that probably is related more to the histamine content.
Oh, and I had a patient this week who parents brought him in because the baby had a rash, and it was from saliva.
Oh, yes.
Right?
Oh, yeah, especially those kids with eczema. Oh, saliva is such a strong irritant. So saliva, for your listeners, you all know, I'm sure that it contains these proteases because that's the first step in digesting food. And so those are really irritating. They're really good at breaking things down. So for a lot of people with sensitive skin, if saliva touches it, look out. It can be really irritating. So my favorite study of all time was they took children with eczema who all had pacifiers or binkies. And then half the group, when their binky fell out of their mouth, those parents put the pacifier in their own mouth to clean it off and then put it back in their child's mouth. And then the other half, washed it off and was hyper clean and stuff like that. And then the ones that put it in their mouth, they actually had less development of allergies and things like that as they got older. So we don't want to be hyper clean. We want to expose our children to the environment that we live in, especially like animals and animals licking their face, animals eating poop and then licking the baby's face. That's the best way to prevent allergies.
Maybe my questions weren't as dumb as I thought. Here's what I learned today. Humans can, in fact, have reactions that are much worse or much less on their subsequent encounters, and unexpected factors might play a role, like exercising or alcohol consumption, and of course, the amount of the allergen that was eaten. And I was very surprised that you can have cross reactions show up on an allergen test as a false positive. Be wary about allergy testing and only do the tests with a board-certified allergist. I saw a patient this week who tested positive for the drug ecstasy on a routine drug screen. It was done for another reason, and they swore they had never touched the stuff. So we actually think it was a false positive from another medication. These things do happen. Thank you to Dr. Dave Stukus. You can find him on Instagram at AllergyKidsDoc, and he hosts the podcast Conversations from the World of Allergy, which I highly recommend if you are interested in titles like The Mysteries of Mastocytosis and Alpha-Gal Syndrome, which I happen to find fascinating. If that's too much for you, keep listening to this show where I will distill down a summary of everything you need to know from the world of allergy. If you want to hear more about how to undiagnose an amoxicillin allergy, listen to the bonus episode I did for episode 42. It's not hard to find. It's called Undiagnosing Amoxicillin Allergies with Dr. Stephanie Leonard. That's in the Pediatrician Next Door feed. And I'm going to leave you with this closing thought.
Question everything that you read on the internet. Be careful with anything that's trending on social media because the facts are often a lot more nuanced than the headlines will lead you to believe. And if you have questions about allergies, go see a board-certified allergist. That's why we're here. We love helping people understand this stuff, and we can often make you feel a lot better.
For more from the Pediatrician Next Door, find me on the web at pediatriciannextdoorpodcast.com. If you've got a question about the weird things kids do, send an email to hello@pediatriciannextdoorpodcast.com for a chance to hear your voice on the show. I'm Dr. Wendy Hunter, and I'm the Pediatrician Next Door. This show is produced by Red Rock Music. Make sure to subscribe and leave a review wherever it is you're listening. I'll be back next time with more.